Okay, so hello and welcome. So good to see lots of familiar faces and names in the audience as you enter, and I can see you coming in and new people too. So great to have you here. We have a really jam-packed agenda today where we return to the laboratory and acknowledging the often impossible task of meeting the 2023 ELN laboratory recommendations in low and middle income countries. We ask, how can we try to get the best out of the CML laboratory? Today's program will roll out in 3 sections. Firstly, we will have BCR-able testing, when and how to test when resources are limited. Secondly, when and how to look for BCR-ABL1 mutations. And finally, when and how to set up high-quality testing laboratories when resources are limited. So our international experts for today are Professor Simona Soverini from Bologna in Italy and Professor Nick Cross from Southampton in the UK. And they will be involved in discussing all 3 sections of the program. Both of them are giants in the CML field who are preceded by the reputations. They're also wonderful friends of the foundation, and I'm delighted to welcome them to the floor today. It's an honor to have you here, Nick and Simona. Welcome.
Thank you.
Thank you.
So our first topic for discussion today is BCR-able testing, when and how to test when resources are limited. And the regional expert who will guide us through his experience in Bangladesh is Dr. Mohammad Ali from Dhaka. He's another great friend of the foundation and a steering committee member of our South Asian CML reference group. So welcome, Ali.
Thank you.
And as you're getting your slides up, I'll let the audience know that I will properly introduce the other experts for the next topics when we come to it. But for now, I'd like to acknowledge that Dr. Zeeshan Ansar Ahmed from Pakistan and Professor Deepak Kumar Mishra from India are in the audience already, and we welcome any contribution that they'd like to make to this discussion too. As Dr. Ali works his way through the slides, we will break at key points and open up for discussion with Nick and Simona in the first instance, and then Zeeshan and Deepak, and of course, all of you, the audience. Okay, Ali, you look like you are ready to go.
Thank you, Arlene, for nice introduction for me. And first of all, I like to seek apology that I have to skip by so many of my slides. And as we, all of us, we want to hear from Professor Pross and Professor Simeoni. First of all of you know that effective management of chronic myeloid leukemia in the way to treatment-free remission relies on accurate initial diagnosis and assessment of prognostic markers, sequential assessment of levels of residual disease, and investigation of possible reasons for resistance, relapse, and prognosis. These are the milestones. These are the milestones of in CML management we have to achieve. And for TFR, we need MR 4.5. These are the minimum recommendation. And more frequent testing of BCR-ABL is mandatory for when drug is stopped. That is why BCR-ABL testing, especially quantitative one, is the essential one. And with this discussion, we like to find out the way how many minimum tests we have to do, though the resources are constrained and we are residing in the lower socio-economic groups. And before going to further discussion, these are the mandatory recommendations for the laboratories. Laboratory must be validated, accredited, and external quality assurance and frequently running of internal quality schemes must present in the laboratories. And I like to present one of my unfortunate patients' case. 44-year-old male farmer, normotensive, non-diabetic, non-smoker, presented on March 2016 to a private hematologist with the complaints of left upper sided abdominal lump with dilating pain, along with significant weight loss in last 6 months. On examination, he is found mildly anemic with moderate splenomegaly, no bony tenderness or lymphadenopathy. And his initial blood count total count was 250,000, and with 20% myelocyte and 2% myeloblast, and both blood film and bone marrow studies suggest chronic myeloid leukemia in chronic phase. And these are the recommended molecular testing testing for us. And we think quantitative qualitative PCR is the mandatory one, along with cytogenetics according to the ELN, as well as for identification of types of variant types of BCR ABL transcripts, and also additional cytogenetic abnormality. But quantitative PCR is not mandatory here for diagnosis, but for baseline study it is mandatory, I think. And NGS only for de novo blastic phase, I think. In this case, his BCR-ABL IS was initially 26.812% with mild hyperuricemia. And finally, molecularly diagnosis done as chronic myeloid leukemia in chronic phase. And regarding risk assessment, fall in intermediate risk according to Sockel and Yelps also. And he was treated with imatinib with hydroxyurea for cytoreduction as first-line treatment. Since then, he is doing infrequently BCR-ABL IS without any due to financial constraint. Most of the times he could not do any BCR-ABL IS. These are the 4 or 5 BCR-ABL IS he did, and no KD mutation done. When alarmingly his BCR-ABL IS raised. On July 22, he enrolled in our CML clinic, and we suggest him for kinase domain mutation and BCR-ABL testing. But due to financial constraint, we cannot do the test. As you know, the most of the time we have to outsource this type of molecular test. And we initially started imatinib 800 in his CML profile. You see the 2 or 3 times his count raised. And 1 year with imatinib 800, 1 year patient was quite well. His CBC quite normal, but CBC revealed quite normal. But on December 23, again, total count begins to rise. And again, we suggest him for BCR-ABL testing and for KD mutation study, but patient cannot do. Only BCR-ABL IS can be done, and this is again relies in high. And without any testing, we started nilotinib, and count falls down, but still he's unfortunate one. And this scenario I am showing you as due to financial constraint, in low and middle income countries, we have to every time we have to compromise the ELN guidelines, and most of the times we cannot do, and we need badly in need of molecular lab, and we can where we can provide BCR-ABL IS and KD mutation test in subsidized price to maintain to achieve the goals. And I am asking any comments from your side regarding this case, if you can say what the additional things I can do for this part for unfortunate patient.
Nick, would you like to start us off?
Yes, thank you for that interesting case. I should just point out that both Simona and myself, we are scientists. We're not clinically trained, so we're very well. We have some expertise in laboratory analysis of CML, but we don't actually treat CML patients. I mean, many points of interest. This case, I think, it was so you did an RT-PCR test, which gave you a BCR-able transcript type.
Yes. Yes.
Was that the test that diagnosed CML? Is that typically how you diagnose CML patients, or are there different approaches in different centers?
Oh, at that time, patient, I only search for the documents. And patient come to our clinic in November 2022, and I found only BCR ABL IS report initially with that, no other additional informative test done, I think, at that time, 2016.
So the patient was referred to you from another center, so they know that other center.
No. Somehow patient come to know that from NICRH, imatinib provided free of cost. That's why in 2022, patient come to our center.
I'm just trying to understand in general how CML patients are diagnosed in your countries. So I'm just looking at the population sizes. I think in Bangladesh, you'd expect nearly 2,000 new CML cases per year. In Pakistan, 2,500 to 3,000. In India, must be at least 15,000. Yes. And presumably only a proportion of these are actually picked up. And I mean, when we wrote, just to talk about the ELN guidelines, so, certainly what the focus in the West is not missing a diagnosis of CML, with the excellent treatments, that's just absolutely wrong. And diagnoses are occasionally missed. And they're occasionally missed by not understanding the limitations of particular techniques. So, for example, if you use RT-PCR screening for BCR-ABL, you need to be aware of these 2% of cases who have variant transcript types, and these are not detected by standard kits and many assays. But is that, do you normally use FISH, or you normally use RT-PCR to screen patients, or do they not have molecular confirmation at all?
Yes, in Bangladesh, most of the times we have to outsource from this type of test reports from India. But after COVID, we have so many RT-PCR machine in Bangladesh, and somehow they started RT-PCR, but not externally validated or accredited. I will show later two of my report from this type of non-accredited laboratory. No cytogenetics done or FISH done for this patient, and we are establishing a molecular lab. I think by the end of this year we will start our molecular lab, and it will be a new hope for our CML patients, I think.
Yeah, certainly. So, sorry, can I ask, is that the similar situation in Pakistan, or is FISH used more widely?
So thank you, Nick, for taking this question. And I like to that for us is not the always the primary case for the hematologist is always referred from the the other cities or other physician like GPs. They refer these kind of physician or the patients to the hematologist or the hem-oncologist. And for us, for testing these patient, we usually, and our hematologist usually done the karyotyping for knowing the Philadelphia positivity, and for its additional cytogenetics for the prognosis purpose. But for molecularly, we are doing FISH and the qualitative and the quantitative PCR with tyrosine kinase domain mutation. But the FISH as not usually recommended for the initial diagnostic workup, as it's not giving the the transcript. But but this has happened in few tertiary hospital in Pakistan, not everywhere. So most of the the cases is diagnosed by bone marrow the bone marrow examination and the histopathology, the HNE, and they refer to us for the molecular and cytogenetic testing. Thank you.
Thank you.
Professor Hemant, would you like to come in, and then Simona afterwards? And also do keep an eye on the chat there. Interesting comments coming up from Marine Khan about practice in Pakistan. Not ones that we need to talk to, but good to keep your eye on the chat and see what's coming through. Hemant.
Thank you, Arlene, and hi, Simona, and hi, Nick. Good to see you again virtually after meeting at the HIHA. And thank you, Dr. Ali, for a wonderful presentation. There's one more scenario which I'd like to point out, which happens in my country, and once in a while we get patients like that. The patient comes with a splenomegaly and leukocytosis, and because imatinib is so readily available and so inexpensive, that with a clinical diagnosis of chronic myeloid leukemia, the patient is started on imatinib without either getting a cytogenetic confirmation of the PH chromosome or a BCR able. And then in a few months' time, when there is no response, counts keep rising, spleen keeps increasing, the patient is sent to us, and then we, kind of do the more detailed workup, and we find out that the patient has myeloproliferative syndrome, either a myelofibrosis or one of the other, ETs or PVs. So that happens once in a while. I don't know how frequently that happens in Pakistan and Bangladesh, but once in a few months, I do get a patient like that. And I'd like to make a short comment on Professor Ali's case. I think if the patient has not responded to a second generation TKI, then there is a very small chance, less than 5% chance, that he or she will respond to, imatinib, and even a higher dose of imatinib. So if I don't have any other option, I would shift to another second generation TKI and maybe expect a 10% chance of bettering the molecular response. But the real options are using ponatinib or using asciminib, and also thinking of a stem cell transplant up front. We don't have ponatinib available in India, even though we have generics for all the 3 second generation TKIs. Asciminib has recently been available in India just about since a month, but it's very, very expensive. So I'd rather transplant these patients and get it done at one go, rather than have them spend $1.5 lakh, which means about like 10,000 US dollars every month for an indefinite period. Over.
Thanks, Ahmed. Simona, and then Professor Ziba would like to make a quick comment, and then I think we need to move on.
I just wanted to ask you about mutation testing, but I don't know if this is the right time, or it will be discussed more in depth during the rest of the presentation.
You see, in most of the Indian centers, when patients come with leukocytosis, usual test that is done is a FIS for BCR able, and the treatment is started. You think that Professor Malhotra said that since the cost of the test is more than the cost of the treatment to begin with, many clinicians who are not hematologists would like to put them straight away as a therapeutic trial, whether the count comes down with imatinib, they put them on imatinib, because the cost is lesser than the cost of the test. So that is one. But as per standard of care, normally people undergo FISH, and a sample also goes for RT-PCR to know the transcript type and the quantification of the transcript, so that the future tests are taken care of, because you need to know whether it is E13 or E14A2 or E1A2, because that is also important. Because when you do subsequent assays for TKD mutation, you need to know the transcript type. So that's the way academic practice is done in most centers. But in the private sectors, and the patients are of different types and they mostly pay out of pocket. So many deviations are done from the standard of care. So that's the ground reality, and I think we have to accept that.
Now we like to go forwards, and these are the varieties of mutation. And in 98% cases, ETH13A2 is found, and E14A2. These are the major types, and all guidelines are for this type of mutation, which encodes P210. Yeah, these are the additional mutations we can found in CP at the beginning, and when in plastic type, whenever we do any NGS, then we can found this type of mutations. And ELN recommend commonly that ASXL1 mutation at the screening is not recommended, and when NGS is only recommended when the patient is patient progress to plastic phase or present at plastic phase. And finally, we can summarize cytogenetics along with FISH or RT-PCR is recommended for diagnosis of CML, and cytogenetics should include to diagnose additional cytogenetic abnormalities, and BCR ABL transcript type should be determined for all cases prior to the treatment, and the possibility of rare BCR ABL IS variant uh, should be excluded. And now I am moving forwards with second thing that what can we do? Uh, can you relax the ELN guideline for low and middle income countries uh, uh, to implement the TFR and management, and we are uh, we can discuss today, or I think experts will make their comment on this, and I like to go forward. And these are only RT-PCR and digital PCR are recommended for test for monitoring, and digital PCR have more sensitivity over conventional RT-PCR, and these two is mandatory, I think, for disease monitoring. And TKI, my Dr. Ansar will say about the TKD mutation when needed, TKD mutation can be done. And instruments for digital PCR is automated sensitive RT-qPCR, measuring the BCR-ABL1 IS, especially Sheffield Gene Expert machine is recommended for low and middle income countries where the experts with this machine doing BCR-ABL expertise is not that much necessary for doing BCR-ABL IS calibrated. In Bangladesh, with Gene Expert machine, we do diagnosis the tuberculosis, and 2 or 3 machines here. And IS calibrated kit also validated kit can be used with conventional PCR and digital PCR. And in-house validated calibrated RT-PCR and digital PCR, these are expensive and needs expert personnel. And definitely digital PCR have advantage over conventional RT-PCR. And samples, only anticoagulant samples used, not heparinase, 4 to 5 ml is adequate, and samples should send to the molecular lab within 24 hours, not later than 48 hours. For resource poor setting, where no facility available, dried blood spot may be sent to the regular mail, and this will reduce cost, but the performance is not as fresh, like fresh sample. RNA should be extracted with total leukocytes, not from mononuclear cells only or other cell fraction. Standard enzyme should use for optimal result. And these are the key steps, and I like to focus on international scale conversion and appropriate reference gene, using the reference genes. These are the two mandatory steps for IS calculation. And most of the times, ABL1, GUSB, and BCR are used for BCR ABL IS for IS conversion. And most of the laboratory uses ABL1, and GUSB rarely used. But when we use GUSB gene as reference genes, it needs 2.4 times more copy to get the optimum results. And for IS conversion, we need the laboratory specific conversion fraction. This is a thing for IS conversion. Conversion factor is the necessary one, and it can be obtained by sample exchange, or using calibrated secondary reference kit or validated kit system that directly outputs the IS results, like in Shepherd Gene Expert machine. These validated kits are used, and which provides the good results. And calculation of IS, these are the formula for calculation of IS. When disease is detectable, some of BCR-able copies is deducted by some of reference gene, and multiplying it by conversion factor and hundreds. When this is this BCR-able IS is not undetectable, then I think laboratories should use more replicates, more replicates, usually 2 or 3, both for reference gene and BCR-able IS. And when undetectable, results should be mentioned as BCR-able is undetected in number of reference gene equal to MR 4.5. And there are some difficulties in detecting atypical, in case of atypical BCR-able transcript. And these have some challenge that results cannot be expressed on IS, and all the guidelines are written for major transcript. And the TFR is recommended for only for major transcript. And there is a question that can we implement TFR in this type of cases? The recommendations are it can be performed by validated RT-PCR or digital PCR, and individual molecular response is the main assessing factor in that case. And most of the case, ELN recommends GUSB for use as a reference gene. And this is the other approaches to MRD testing. This is now DNA-based MRD analysis is come forwards, which is easier to standardize than RNA-based analysis. And another methods come forward, single gene genomic analysis, but both of these methods are not recommended by ELN, and single gene genomic analysis is not yet ready for clinical use. So at this point, I like to ask Professor Kos and Professor Simona that is there any easier methods we can use for under-resourced country or resource-constrained area for doing the BCR ABL testing instead of RT-PCR or digital PCR?
Simona, would you like to kick off?
Yeah.
I think it's better if Nick starts.
Yeah, I mean, several points. So I think the question was based around monitoring, and particularly in the context of treatment-free remission. So we know that only patients who have sustained deep molecular responses, is it MR4 or better, for a bare minimum of 2 years, preferably longer, 50% of those can successfully stop treatment and remain in TFR. 50% will relapse. And if you have higher levels of disease when you stop, the great majority of those patients will relapse. Initially, when the guidelines were constructed, the recommendations were constructed, there was a lot of concern about stopping treatment, that patients may relapse, that they may have adverse outcomes that could have been prevented if they stayed on therapy. And there's no way getting around the data, really, that you need these optimized PCR tests, whether it's qPCR or digital PCR, to detect deep molecular responses, and you need sequential tests over a period of time to determine that deep molecular response is sustained. And then, very importantly, if you stop treatment, you need those sensitive tests to detect relapse. Now, the focus has been very much on molecular relapse. So this is not a sign of imminent transformation or imminent death. This is a very low level, essentially, increase from a log reduction of 10 to the minus 4 to 10 to the minus 3. So the leukemia cells are still, CML cells are very much in the minority. Now, if you completely didn't do that at all, if you didn't do any molecular monitoring, well, we don't have the data to know the outcomes, but we can predict that the great majority of patients, if you didn't do any molecular monitoring, would relapse if you stop treatment. And if they do relapse, then there's going to be, and their disease has previously been controlled, there must be an increased probability that those patients might progress. It's very difficult to say how the guidelines could be relaxed in the absence of adequate data. So I would really encourage you all to gather your experiences and publish them. I think we all feel instinctively that the frequency of monitoring could be reduced safely, but to what? In the absence of evidence, it's very difficult to give any kind of definitive statement. We just had discussions in Madrid about the frequency of monitoring after stopping treatment, which at the moment the recommendations are monthly for the first 6 months. And I think most people feel that's excessive, but there's a general consensus perhaps that could be reduced to once every 2 months. That's still a lot of tests, and particularly in the context of imatinib being free and the tests being expensive, it's a very interesting sort of inversion of the scenario that we're used to here. I'm all in favor of local guidelines that are adapted to realistic local resources, but it's difficult to see how they could be constructed without, you need the evidence ideally. If you haven't got the evidence, you're going to have to make some sort of arbitrary decisions. So I'm kind of waffling here. There's no simple answer, is there, into what you can reduce. But I think there's a general sense that yes, monitoring could be safely reduced, but to what? I don't know. And it's inescapable fact that if a patient isn't in sustained deep molecular response for at least 2 years, those patients will relapse if you stop treatment.
Deepak, would you like to
Yes.
comment?
You see, the thing is, what Nick said, that, in India, we have at least 20 generic imatinibs available right now. And the cost of a month's treatment is about 50 USD. And the cost of the test is about 80 USD. So the number of times the patient needs to be tested, say as per the ELN guideline, first at 3 months, then 6 months, and then 12 months, and then you look for the major molecular remission at 12 months of 0.1%. And after that, I think it is done once in 6 months. So that's probably doable if the patient is getting service in a hospital where the test is done free. But if you want to go for the treatment-free remission, the tests have to be more often, and majority of the time the patients are not able to afford. And as Nick had said, to achieve deeper molecular remission like in the IS 4.5 or 5.0 for a sustained period of 2 years, at which you can take a decision to put the patient on TFR. And at that stage, probably about 50% of them, they still will come back with some relapse, but 50% will be off imatinib, and that's a big achievement. So country to country, hospital to hospital, within the geographic region of the country, things will differ based on the financial resources the patient has. So I think we have scope to further reduce the cost if we can transport the sample to a reference. You see, the thing is that when you transport the sample, in the Indian context, India is a country which is a tropical climate. The temperature in the summer goes up to 45 degrees. And at 45 degrees, if you send the sample, the RNA is highly degradable. And if you want to use the streak tubes or the Paxton tubes for the stability of the RNA, it adds another $25 to the test. So it becomes almost 100 plus. So those are the constraints that we have in the resource constrained countries. The transportation of the sample is a big challenge because of the huge high temperature that the environment has. So these are the issues that needs to be looked at.
Can I ask,
May I come into?
Sorry, is there a strong motivation for TFR? Do you find that many patients do want to stop treatment, or actually they, I mean, if you take away the financial aspect?
No, many patients have to start on to avail the TFR facility. Yes.
We've just
you've been Ziva's been trying to come in.
Oh, excuse me. We've been looking at TFR, and one of the major problems with TFR is that the patients are getting imatinib for free, and the BCR-able testing is expensive, so they generally tend to not do it. What we've done, and we've been very successful, is taken patients who are on not deep, by FISH, they have been in a major molecular response for 4 or 5 years. Then for 6 months, we do RQ-PCR, and after that, TFR. But we are not doing it every month. We are doing it 6 to 8 weeks according to the affordability of the patient. And since the duration of imatinib has been very long, we've been able to have 50% of our patients off imatinib, and currently right now, the first patient is in 7 years without imatinib. So we've been pretty lucky with that, and we are using a rigid protocol of 6 to 8 weeks in the first 6 months, then 3 months, and then we are going to 6 months. I know that we may be missing something, but I think we're catching most of our patients, and it's not that expensive, even though it costs them money. And initially, these are all patients who come from public sector hospitals, marginalized patients who cannot afford it. So they are getting their FISH testing, and if they have a major molecular response after 5 years and continue to be in that, we go for our qPCR, and this is how we are doing it for our marginalized patients. For our patients who can afford it, we are looking at EML guidelines and saying, okay, let's do it that way, or just not doing it once a year unless and until there's a drastic change in their peripheral blood or there is a sign of splenomegaly. And I think we are doing pretty decently because of education of all our patients. They come forward immediately.
You see, the thing is that majority of the patients who fail TFR are in the first year of their being in TFR. So until unless you follow them up every month for first 6 months and every 3 monthly for the next 6 months. So this first year is very crucial for TFR because that is the time when TFR failure happens. And anybody
we do that. It's not, CBC is done every month, but the RQ-PCR is done 6 to 8 weeks, and we found that we are pretty good at it. And we are writing a paper on that, and the savings that we've made by following our guidelines. And I think it's reasonably well.
Ziba, that sounds great. We'd love to see that paper once you've done it. And I hate to do this,
So
but I have
I
one
have
eye on the
one
time.
comment if I can.
And then we really need to move on because Dr.
Yeah.
Ali, I know what's at the end of your presentation, and I'd love to
Okay.
get there. But yeah, we need to move on. Go on, one quick comment,
Okay,
please, and then we'll move on.
This is the price that we have to for qualitative cytogenetics we have to patient have to spend $76, and most of the times we have to outsource here. And quantitative PCR $72. There is I think most of the times poor patient cannot afford this type of test with this cost. And finally, I like to say something about the ideal RT-PCR BCR report. And report must have transcript variant, line of therapy, result reported in IS only, and reference gene should be noted. And the amount of references must put, and the test sensitivity also mentioned in the report, and notification to the physician is also recommended. And this is the ideal shape of a report. But before ending my presentation, I like to show two of faulty reports. And this is from the some laboratories in Bangladesh doing BCR in without any validation in after COVID. And this is a report that has no IS copy test sensitivity and any other things. And I think this is not an appropriate report for CML patients. And another report, this is one report. This is I think this is a ridiculous types of report. BCR reveal copy 104, but reference date is 2264. How can they report as the IS 5.65, whereas the conversion factor is not mentioned? And I think this type of report is not appreciable or from molecular laboratory. And laboratory must be validated or accredited, and test sensitivity should be mentioned. And finally, I like to comment about these two reports from the experts and others. Uh, if any comment on, and that's why
I would
that's
like to say something here.
yeah.
You see, the quality control is extremely important in molecular tests, particularly in BCR. So we have in India something called NABL, National Accreditation Board of Laboratories, who accreditates the various laboratories. So when I'm an assessor, when I go to assess various labs, you see, ideally, even Nick also will agree, they put in triplicates. In India, many labs, they don't even put in duplicates. You see, it is very essential that the tests should be put in at least in replicates, because to avoid errors, because you see, we are doing manual pipetting. So instead of putting into individual tubes, you may put the sample twice in a well, or even some of the wells may be missed. Because what CAP guys, somebody contested me in one of the assessments that CAP doesn't say that you have to put in replicates, because they have liquid handling platforms, everything is robotics. So the error of pipetting is not there. But in countries like us, Pakistan, Bangladesh, India, where everything is mostly 99% is manual pipetting, it is very important that you must put the samples in replicate, because if the two tubes don't match and there is severe discordance, you have to discard the result and repeat it. So if you contest this, then the private laboratories will say, then how do we earn profit? Because the cost of the test is highly competitive. Labs fight between each other. They try to be very, very competitive to give cheaper tests. So that is one issue that needs to be addressed, because quality cannot be compromised. So the thing that you saw 2,264 C-able amplification is just not acceptable. So this test shouldn't have been given, the report shouldn't have been given out, rather than it should have been repeated. I think the cDNA must have been of a very poor quality.
And I
Nick,
think
what do you think?
this sort of reports is is avoidable. We have to avoid this sort of laboratory. And finally, I like to say something about our future hope. By the end of this year, we launch our molecular lab in National Institute of Cancer Research and Hospital with conventional PCR, real-time PCR, Sanger sequencing, high-resolution HLA typing facility, and test should be facilitated by 60 to 70% subsidized price from our government. And uh, before ending, I like to acknowledge iCMLf, International CML Foundation, for giving me the opportunity to present present, and Dr. Sufianan Mohammad Zulfikar Rahman, the only immunologist and molecular biologist we have, and uh, we're hoping we will facilitate our people soon. And thank you all participants and experts for patient hearing. And I think it's a great opportunity for me. And thank you.
Thank you so much, Dr. Ali. That was great. And I'm so sorry we have to stop there. Possibly we'll
Yeah.
have some time at the end for other questions if we can come back to them then. But you raised so many good things. Thank you very much to you and to our experts and others in the audience for your wisdom. Again, thank you very much to Dr. Ali. That was great.